I just wanted to remind us all, and this is just sort of going back to basics now, about when we talk about somebody with intellectual disabilities or learning disabilities, this is what we're talking about. And I'm sure you all know this, but just to reiterate, you need to have both impairment of intellect, social impairment, and they both have to be whilst the brain is still developing, so before the age of 18. Now, these are all arbitrary cut-off points. So they're not, it's not as straightforward, you've got an IQ under 70, 2 standard deviations below the mean, therefore, you've got intellectual disabilities. It's much broader than that. But you do need all three to be given the label of having intellectual disabilities. The prevalence, it's about 3% for children, 2% in adults, and that's because of mortality rates, basically. So we're talking about 1.5 million people with intellectual disabilities in the UK and 1.2 million with mild to moderate disabilities. And the prevalence is expected to rise to about 10% by 2020. As Valerie has said, severe intellectual disabilities is very evenly spread in the population, but mild and moderate is much more linked to poverty and urban areas of deprivation. So a GP practice list, with a practice list of about 2,000 people, will have 6 people with severe intellectual disabilities and 44 people with mild to moderate disabilities. So that's quite a lot. And what we do know is that although they're there on the practice list, only about 23% of them will actually be identified as having intellectual disabilities on the register. So that has huge implications for how we might want to go about doing reasonable adjustments or whatever that we need to do in terms of making care more accessible. The other thing that's really, I think, quite a helpful concept is the World Health Organization concept of impairment, disability, and handicap. So we can have a visual impairment, but it doesn't really have to affect us that much if we wore glasses, for example. But if you're wearing glasses, and you still find it very difficult because the lighting is bad or the text is very small or signage is small or you're very far away, whatever, then the environment handicaps you. And so there is a difference between an impairment, a disability, and a handicap. And so we can do an awful lot in terms of how we configure our services, how we work with people, so that although they may be disabled, they're not handicapped in what we're trying to achieve. To remind us also that intellectual disabilities is not a mental illness. It is a developmental disorder, and it's a social construct in the main. But the group that we're talking about are very heterogeneous. So we're talking about people with very mild to borderline intellectual disabilities where it's quite difficult to recognize maybe. They may be revolving doors, patients who are coming in and out all the time but don't quite understand the care plan, don't quite understand the treatment, right through to those with profound multiple disabilities where they are dependent on other people for their care. And a lot of people with intellectual disabilities have huge numbers of comorbidities. So, for example, someone with Down syndrome could have intellectual disabilities, although not always. They're much more prone to have hypothyroidism, congenital heart disease, sleep apnea, sensory problems, chronic lymphocytic leukemia, Alzheimer's-type dementia. And these are just examples, they're not a whole list. So part of King's Health Partners, of course, is about trying to integrate physical and mental health care in terms of how we deliver services. Another example is Prader-Willi syndrome, which is a chromosomal 15 abnormality, which is characterized by compulsive overeating. So you get food poisoning, you can get choking, you can get gastric ruptures, you can get obesity, obviously, diabetes, heart problems, behavioral problems, particularly when you're trying to stop excessive food intake, and they're much more prone to psychosis. And they may or may not have an intellectual disability with it, although most of them do. And then if we just think about intellectual disabilities on its own, 3% of the population will have schizophrenia. That's 3 times higher than the general population for schizophrenia. About 30% of them will have autism as well, and 50% of people with autism have intellectual disabilities. So again, it's a comorbidity that we have to remember. Most of them will, if they have schizophrenia and autism, will have medication. The medication gives you side effects in terms of metabolic syndrome. So again, you have all the physical health problems associated with that. And of course, a lot of people with intellectual disabilities have epilepsy. So again, it's just to remind ourselves that it's not just mental health or physical health, although when I'm talking later on, I will have to do the two-prong approach. So this is just a very brief overview in that about a century ago, most people with intellectual disabilities were cared for in large institutions. And the institutions, when they were set up on a sort of social improvement model. They were trying to replicate public schools like Eton and Harrow and trying to give people the best care they could at the time. But within 2 generations, it's basically deteriorated so dramatically with excessive reliances on medication and physical restraints. And a growing awareness that actually institutionalization was really not the way to go. So the European Convention of Human Rights in 1950 did recognize the damaging effects of this. And then in 1969, this is a whistleblowing incident with a healthcare worker, went to the News of the World and really reported really awful care at Ealing Hospital. And it led to the 1970 white paper, Better Services for the Mentally Handicapped. And that paper called for a reduction in hospital beds and a reduction of about 50%. And at that time, and this was the time when, in fact, in the 1980s when I was training, I would trained both in hospital and community services for intellectual disabilities. And I remember my consultants being so anxious because the institutions were closing down and they didn't know what role they would have in the community. And a lot of them gave up working in the NHS and went into the private sector, where the private beds are still quite high. So not a lot has changed between 1970 and 2001 when the next white paper came out. But the next white paper was much more about social inclusion, about trying to include people with intellectual disabilities in mainstream services. And the real message was for us in terms of service providers was that we should be looking at just a small group of those with the most complex needs. And otherwise we should be trying to support other services to provide the care. Mainstream services provide the care. And so Green Light Toolkit and all these other things happened because of that. And this also led to enhanced services for GPs and annual health checks. And it led to a whole host of other things, partnership boards and various things. At the same time, and I won't go through this all, but we will know there are examples of scandals and inquiries that have happened throughout the years, the most recent being the Winterbourne View scandal, which was people with intellectual disabilities and autism in a private hospital trying to care for their challenging needs, but the way they cared for them obviously was scandalous. And this led to this conclusion, that actually on the rare occasion, when an acute inpatient ward is not appropriate, people with intellectual disabilities should be treated in small services specifically designed to meet their needs, but managed within mental health services. It will probably provide assessment and treatment beds for people with intellectual disabilities and challenging needs. There must be collaborative and specialist commissioning. It must also ensure commissioning for those with mild intellectual disabilities, autism, and Asperger's syndrome. So that's what it said. But actually, this came out in 2001. This was from the London Strategic Framework. So it's the same recommendations all the way through. The Winterbourne View Concordat, of course, now is really trying to reduce the numbers of beds, trying to promote the discharge of people from hospitals. And yet we see from this chart, and this is 3 months in 2014, so on your left there are the numbers of people who've been admitted into hospital, people with intellectual disabilities being admitted into hospital, so 404 in total in England. And this is the number of people being discharged. And you'll see that the numbers going in are still far more than the numbers coming out. The red bar are the people admitted into CCG-funded facilities. So these are mainly local acute assessment and treatment facilities or acute adult mental health wards. The green bars are the specialist commissioning services. So those are mainly private sector, mainly low secure, medium secure units. So we have a long way to go, obviously. The other sort of prong approach that I wanted to remind us about is physical healthcare. So in 2006, the STS Centre, in fact, did quite a lot of work pulling together the evidence about health inequalities and physical healthcare issues for the Judas Trust and the Disability Rights Commission. And this led to the publication of Closing the Gap in 2006. And it was followed very closely by MENCAP's report, Death by Indifference, with 74 people with intellectual disabilities dying in hospitals unnecessarily. And these two reports together formed the basis of the Michaels inquiry. And Sir Jonathan Michael, if you may remember, was a former chief executive of Guy's and St Thomas's Hospital. And this Healthcare for All report came out in 2008, and it really, has really profound findings, but it talks about people with intellectual disabilities not being visible or identifiable in hospital services, and hence the quality of their care is impossible to assess. And as I said, since then we've had directly enhanced services, and we also have the confidential inquiry into premature deaths, which Pauline will be talking about this afternoon, so I won't actually touch on it. So now we're expecting most people with intellectual disabilities to at least be offered an annual health check by their GP. And this slide's come from Giles Glover, who is director at Public Health England, and you'll see that fewer than 50% actually have annual health checks. And of course, we have to be opportunistic if we're going to really identify health needs for this population, because the health service is set up in a reactive way rather than the proactive way at the moment. And then looking at local services, so I work in Lambeth in my clinical practice, so I'm just using Lambeth as an example, although I think they're very similar in all the boroughs that we've got. This is all from the public health profile that's on the website, and this is a 2013 report. I was trying to get the 2014 one, but I'm not sure it's out yet, although Giles did promise me he was going to send it, but I haven't got it. So the black line are the number of people with intellectual disabilities known to a GP in England. Okay, so in England it's about 4.5 per 1,000. And as you know, we should be expecting 20 per 1,000. So 4.5 is the best. The blue line is London, the average in London, and the yellow line is Lambeth. So, we're sort of on the right track in terms of average for London, for known identified in the GP practice. This is the number of people who were receiving annual health checks when they were eligible for it. And I don't know why it's dropped, but it may be something about the way it's recorded or the way it's paid, but this is in the public domain. And you'll see Lambeth is right down there in one of the red, as are most of the London boroughs that we serve. Identify people with intellectual disabilities in hospital. And again, you'll see that we're not doing very well either. And again, Lambeth is down there in the red. So there's an awful lot that we have to do. And this is another way that it's being graphed. So these are spine charts, and you'll see can you see it all? These diamonds are the national average. Are the regional average. The red lines are the national average. And then this is how we're doing in comparison. So you'll see that actually in Lambeth, the third row down, in Lambeth we actually have quite a lot of children with autism or with multiple disabilities. But they're not very well known in terms of GPs, as we've said before. But actually we spend an awful lot of money on services. So actually, if we can think of other ways of using the resources that we've got, I think we'll be on the right track. I wanted just to share a little bit of some of the research that we've been doing recently. These are preliminary results because we're having to reanalyze some of the data. But we know that the prevalence of respiratory disease is very high in people with intellectual disabilities, so it's about 50% compared to 15-17% of the general population. And the respiratory disease is one of the most common causes of preventable premature deaths for this population. Within the Mental Health Trust, we now have a database, an anonymised database, which has 235,000 individual records. And what we did was we then looked at how many of those had intellectual disabilities as a diagnosis, either as an ICD-10 diagnosis or when we text mined for it in terms of correspondence and reports and things. And about 1.3% we found within our database. What we did then was that we linked it with the anonymised hospital episode statistics, which is a HESL data, to look at how many of those people actually had admissions for respiratory disease in any acute hospital in England. And we then compared that with the expected admission ratio and what's currently happening for the rest of the population. And we found that people with intellectual disabilities, the standardised admission ratio is about 2.4%, sorry, not percentage. We also match for age, for gender, and for the number of physical comorbidities. So intellectual disability on its own, as the only single variable, would give you an average length of stay of 2.5 days longer than any other person. And the risk of readmission is higher. So we're analysing this data and seeing what we should be expecting, how many should we be expecting on our wards, and can we recognise them, and what care are they being given, and why is their length of stay longer. The other thing just to highlight is that this cohort, of course, is very different from the cohort that's already been published, because the cohort that's already been published is much more people with profound or severe disabilities, where respiratory admissions is because of aspiration pneumonia. The admissions are really influenza and pneumonia, which are treatable, and you shouldn't have to be in hospital for that. The other thing I just wanted to briefly mention, which affects clinical practice an awful lot, is diagnostic overshadowing. So 2 examples, fairly recent examples. One was a home visit that I did last year, and it was a woman in her 50s who was well known to the local community mental health team. She'd had a previous admission for depression, and when they admitted her, her presentation improved quite dramatically, so the assumption was that actually it was mainly environmentally driven. And they discharged her, but she gradually deteriorated over the 12 months, maybe 18 months actually. She wasn't really engaging with anything, and she was at home. And so they referred her to us, thinking that maybe if we could help with some facilitation for engagement, it would make a difference. So I went to see her with one of our clinical psychologists, and we met her with a support worker. And the team, of course, were very aware of her intellectual disabilities and wanted to do something different to help her. But once we went into the room, it was very evident that she had severe depression. She had psychomotor retardation, and she was catatonic, and there was no way she had any capacity to have made a decision about whether to stay at home or not. And we ended up using the Mental Health Act and admitting her into hospital. The other example happened just last month. It's a young man with intellectual disabilities admitted via the Mental Health Act on the 136. He went into hospital, and there was a lot of concern because nobody really wants to admit somebody into hospital post-Winterbourne View. So there was a lot of sort of anxiety around that anyway. And the team basically thought of it very much as a social admission and nothing to do with mental health. But they were very keen that they wanted some help because they thought they were missing something, and what they were missing was about his intellectual disabilities. And they didn't quite know how to treat his challenging needs, and shall we use medication, all this sort of stuff. And so I went to see him with my trainee, and in fact he was floridly psychotic. But the team missed it because they were so distracted by the fact that he has an intellectual disability. So although on the one hand we need to be very aware that people have intellectual disabilities and how we adapt our approaches, on the other hand we also cannot allow it to overshadow what is presenting to us and treating it accordingly. So where are we now? Well, most of you will know the BUB report was published in December 2014, and it really talks about strengthening rights. And this morning, Norman Lamb is going to, or has announced, the consultation on rights for people with intellectual disabilities, and the right to challenge admission, and the right to have something different from an admission into hospital if services exist. So the consultation's been open for, I think, open for 12 weeks or something. So so hopefully you'll be able to input into that. And learning disabilities has now become one of the top 4 clinical priorities for NHS England. And it's very much about delivering on the pledges of the Winterbourne View Concordat. It's very much about the confidential inquiry into premature deaths. And crucially important, it's about how we educate and train our workforce to deliver a different sort of service. So these are the key messages that I'd just like to share with you and remind you of. Health inequalities, mainly due to delays in diagnosis, mainly due to the fact that we actually offer different care pathways for people with intellectual disabilities. There's an awful lot about diagnostic overshadowing that we really need to address. And we do have a culture of indifference, both professionally and in organisations, that we need to challenge. But there are realities in the workforce, and the realities are that we are all under a lot of time pressure. We're all under huge amounts of pressure to deliver on activity and targets and various things. There's a lot of silo working, and there are organisational obstacles that we have to overcome. There is genuine confusion about the Mental Capacity Act and how we might implement it. And it can be very complex. It's not straightforward. If it was, we would have done it long ago. And most of our workforce, there is very little training or support. So this day is hopefully the start of us trying to develop something locally that will support workers across King's Health Partners and across our AHSN as well, in terms of community and primary care, to see if we can actually address this and work together. So I'm going to finish here and hand you over to Karina, who's going to talk about the HESL project that is the core of this day. Thank you very much.